So this is a very big topic, and Robert's comment about this being an amuse-bouche is a really good one, because really what we have to do in order to talk about telepsychiatry is to subdivide the field and start to define what we mean by that. Traditionally, there have been there's been overlap between what's defined as telehealth and telemedicine, telepsychiatry being a subset of telemedicine, a subset of telehealth. Really, right now, what we're talking about is an entire spectrum of online and digital interactions with patients. And when we talk about telepsychiatry, we are very specifically talking about real-time communication between provider and patient. So it's a mode of remote health service delivery. It's provided in real time, so at the time of care, as opposed to a store and forward or a delayed sort of communication. It's synchronous and it's two-way, and it's performed using video and audio on an electronic modality of some kind. So this really scopes things down to some extent, and really at its core, this, while it used to be thought of as such a futuristic and innovative technology, it may be the most traditional of all the things that we're talking about on this panel today, which really shows how quickly technology becomes incorporated into mainstream and then very quickly used in healthcare. So I think that the position statement on telemedicine and psychiatry by the APA really defines what I'm hoping to focus in on a little bit, which is the problem of access. And Robert early on mentioned that the severe shortage that we have, and I think this encapsulates it nicely. There's a shortage of psychiatrists in areas of the country, especially rural areas, contributing to inadequate access to high-quality psychiatric care. Telepsychiatry using video conferencing is an essential strategy to increase access to high-quality psychiatric care. So in the problem that they're defining, they're posing a solution as well, and I'll come back to what their resolution ultimately was. But really, much of the goal of telepsychiatry is to provide access in an ecosystem where child and adolescent psychiatry is very, very hard to access. So as Robert mentioned, the critical workforce shortage is both an absolute shortage and a relative shortage, or regional misdistribution. So in addition to having one child and adolescent psychiatrist per 1,800 patients, there's an even more focused need in some of the rural areas and some of the urban underserved areas. So this can be stunningly large, this deficit. The role of telepsychiatry, the aim of telepsychiatry is to extend a psychiatrist's reach across a large geographic area, which reflects some of the early use cases in rural areas where there would be a large section of the population that would be out in remote areas, and it would be prohibitively distant to come to an urban area to get specialty care. So much of the early telepsychiatry was in that environment. It's increasingly being used for targeted patient populations for subspecialty care. We've heard a lot about CBT. CBT is a particular modality that if you can't get it, you can't get it. And if you're not doing CBT, you're not treating anxiety, we heard. So you need a CBT therapist. So how do you do that if you're out in the distant part of Alaska and the closest CBT therapist is Anchorage? So these are the kinds of use cases that drove this to be part of the mainstream health delivery system. So it's really not a new idea. In 1924, 1925, as soon as the radio was developed and telephony was developed, the idea of providing real-time services through this sort of encounter was in the public interest. 1962, Elroy sees the doctor. This is a video visit. I mean, every bit as much as we're doing it today. And so that prompted Kathleen Myers, in her paper in the Journal of American Academy of Child and Adolescent Psychiatry, said telemedicine has been right around the corner for 5 decades. So this was written about 5 years ago. It's getting close to 6 decades. I think we're a little closer, but we're still working on adoption. She also has another great quote, which I'll share with you later. So this is a timeline of the actual implementation of telepsychiatry over in the last 50 years, 59 years. So in 1959 was the first use of interactive video to deliver health. That was at the University of Nebraska. NASA had experimented with the technology before, and as you can imagine, early in the adoption curve, technology was the main limiting factor. So once that was overcome, then the large medical centers started to get involved. You'll notice that Mass General Hospital provided a distance-based telepsychiatry, that was the the word that was coined for the first time, to provide services to Logan Airport from the ER at Mass General, and other developments along the way. So this is the position statement from the American Psychiatric Association. I think this really is telling, because if I had been talking to you 3, 4, 5 years ago, I'd be pulling together a lot of small studies and case studies and personal experiences with telepsychiatry, and there wouldn't really be this literature base that would allow a major professional organization to say unequivocally that telepsychiatry is part of the spectrum of care, and they do. Telemedicine in psychiatry using video conferencing is a validated and effective practice of medicine that increases access to care. The APA supports the use of telemedicine as a legitimate component of a medical health delivery system. And then they talk about some of the potential limitations, the extent that its use is in the best interest of the patient, so appropriateness, protects patient autonomy, this is privacy and ethics, confidentiality, privacy, and when used is consistent with APA policies on medical ethics and applicable governing law. That last 3 words is a big part of the reason why we are still right around the corner from telepsychiatry. It's that applicable governing laws. So the role in the ecosystem of healthcare has been quite diverse, actually, about as diverse as the delivery of healthcare is in person, or can be in person. Pediatric telepsychiatry evidence generally lags behind that of adults, and so like other parts of pediatrics and child and adolescent psychiatry, we often extrapolate best practices and evidence from adults, and then we just divide it by the fraction of weight, right? But we can't do that here. So we can get a sense of how some of these modalities are adopted and used and how they benefit access in the adult population, but we can't always predict in a pediatric population. But we can start. There is increasingly a body of literature that's specific to pediatrics, and my hope would be that there's some interest in this room, and this folks here would go out and add to that evidence. One of the things in particular that's rather challenging is that there's limited criteria for determining patient appropriateness for telepsychiatric care. So, you know, the optimal use case, for example, it's hard to kind of identify what that might be. We're starting to get a sense of who might be better with a telepsychiatry encounter and who might struggle a little bit more. That said, there's no absolute contraindication to use of telepsychiatry except for refusal by the patient or the parent. There is no disorder, no condition where telepsychiatry can't be useful. That's not to say that care doesn't need to be escalated for urgent or emergent concerns or safety issues that arise, but telepsychiatry can be a useful part of the treatment in order to help triage and move people along in the assessment process to an appropriate level of care. So early on, telepsychiatry played a role in the traditional medical setting, mostly in the outpatient clinic, and mostly in settings where you were doing a kind of a hub and spoke model. That is to say, providing medical services out to distant, remote locations where the patients were, but some kind of medical office. So there were some early regulations that required, full set of vital signs, and that it be in a particular kind of setting. In fact, some of the Medicare legislation still has much of that built into it, which is a barrier to reimbursement in Medicare. But the setting in which the patient would receive care would be a medical-like setting, but the physician would be in another remote setting. So that would be the originating site where the psychiatrist is and the receiving site where the patient is. So inpatient psychiatric treatment, you'd think that would be a natural place for adoption. There is this concept of a telepresenter, so someone on the other end that helps usher the patient through the encounter, helps fiddle with the equipment or turn it off and back on again if it stops working. These are the kinds of things that you would think would naturally fall to a team-based approach and be used very, very readily. In fact, that's not true. There are some regulatory and reimbursement issues that have slowed that process, as well as the concern for reciprocal credentialing, which did not exist until within the last year or two. So my experience actually is a unique one in that I had more than a year of providing inpatient services via telepsychiatry, and we can talk about it a little bit in the discussion, but it is a remarkable experience. It's very team-based, and I think people who are exposed to telepsychiatry are surprised at how much the relationship grows in similar ways, and the interactions are as nuanced as they are in person. And sometimes there are things that you can pick up on video that you may not be able to live. So that's direct patient care. There's also a consultation model where a psychiatrist could provide outpatient consultation to a pediatrician, for example, or an inpatient medical unit and provide CL or psychosomatic consultation, and also subspecialty. So in areas of the country that might have an adult psychiatrist, a child and adolescent psychiatrist could provide additional recommendations. So we're increasingly looking at where else to provide care, and this is particularly helpful for children in that we're often looking at ways to remove or subtract back out the impact of the setting in which they're being observed. It's like the Heisenberg uncertainty principle for kids. By observing them, they change. So the more we can get them out of an artificial environment and back into their home environment or their school environment, the better the assessment can be. And parents are often great built-in telepresenters, so there's not a strange person in the room. And when they leave the room, we can see how they deal with strange circumstances or separation. And that a lot of early child and adolescent psychiatry is about attachment. So for all these reasons, some of these use cases that are in traditionally non-medical settings actually are very, very relevant. So the home setting, which is becoming increasingly adopted, school-based telepsychiatry, and juvenile corrections. So I hinted at some of the factors that are impacting growth and adoption. And I would say we're turning the corner on some of these, and there are others that really have a long ways to go. The technological factors, you saw back in 1959, the early telepsychiatry, after it moved out of multi-billion-dollar, million-dollar NASA contracts, it became something that was expensive and cumbersome and not accessible to everyone. Whereas now, the computational power in the phone that we carry around with us is mind-blowing. So I think we have a very good sense that the technology is growing. It's ubiquitous. It's easy to access. It's the kind of idiom that people are much more familiar with. And so the technological factors and limitations really aren't as much of an issue. There's increased broadband coverage across the country, which allows for the communication necessary for two-way video and the end-to-end encryption that provides the HIPAA compliance. So for these reasons, these are much less of a factor than they were even 10 years ago. Financial factors, the degree of reimbursement coverage and parity at the federal, state, and a private insurance plan level has been growing. So as of 2017, all states and the District of Columbia have some kind of reimbursement at the state level. That's not to say that reimbursement and payment are the same. The contracting, the accessibility, and the networks may not line up with full parity, but increasingly we're seeing adoption at the state level. The federal level, I alluded to Medicare and and some of the requirements for originating and receiving sites. That's still a bit of an issue, although as those get removed, and this will be more relevant for the aging population, but telepsychiatry for geriatric telepsychiatry in particular will be able to roll out in a much more robust way. So in terms of private insurance payers, 35 states in the District of Columbia have reported parity requiring private insurance plans to cover telehealth services, and 7 other states at that time had proposed plans. Now this continues to expand slowly, but it is really sweeping the nation in a very slow crawl. In terms of legal and regulatory factors, there's state variation, flux, and incongruence with federal regulations. And this is a real concern because if you are providing services across state lines, you have to be licensed and follow regulations both in the originating state, in the receiving state, and you're subject to the federal requirements as well. This is really complicated, and people frankly can't keep up. Even the lawyers who specialize in it are opining about what the case law might look like if this ever got litigated. This is compounded by state-based licensure in medicine, and I've highlighted that because I'm going to come back to that very briefly, and limitations on prescribing of controlled substances via telemedicine, which was an accidental legislation via the Ryan-Haight Act of 2008. There are also some interpersonal and adoption factors, patient familiarity and comfort with the medium, which you can see kids kind of looking at magazines and trying to expand pictures like the magazine's not working. They're so used to a digital medium where things move and they can interact in a very, very tactile way. This is not as much of an issue. Likewise, psychiatrists are increasingly receiving training, although the ACGME still doesn't have requirements specifically for telepsychiatry. The exposure is more available. So there's been a lot of talk about national licensure or multi-state licensure. The Interstate Medical Licensure Compact allows for an agreement between states that would allow for multiple states to be licensed. And this is a new and very, very important development and something that's really changing the landscape and ability to provide care. And then the Ryan-Haight Act. So 2008, the goal was to avoid pill mills or online illegitimate pharmacy practices. It inadvertently created a situation through which telemedicine couldn't be practiced. Controlled substances couldn't be prescribed until an in-person visit was done, which really limited the scope of telepsychiatry. It's expected that the DEA will remedy that this year. The deadline was last week. And interpersonal factors and training factors. I mentioned there's the concern about exposure to the medium and also the ability to establish a rapport and therapeutic alliance in telepsychiatry. And I thought that this other quote by Kathleen Myers was great for this population. Perhaps questioning whether it is possible to establish rapport and a therapeutic alliance through telepsychiatry is irrelevant in a time when online friending and video chats already attest the power of virtual relationships, particularly for adolescents for whom such communication is normative.